Good morning, everyone. We're just letting all of the attendees in, so we'll just give this a minute while those numbers continue to go up, and then we will start shortly with a land acknowledgement. So we'll just probably wait for about 2 minutes here. Okay. All right, so good morning and welcome. My name is Kimberly Betts, and I will be your moderator today. I am the Knowledge Mobilization Lead here at CIPCERT. So we're just going to start with a quick land acknowledgement, and then we'll do some introductions and some housekeeping, and then we'll get started with our presentation. So before we do the land acknowledgement, I should mention there is a Wordly option for transcription or translation. Kara will pop those instructions into the chat box for you. So they should be there. Just follow the instructions and you should be able to get an audio or a written transcription for French. So CIPCERT does acknowledge the importance of the land that we each reside upon. We do this to reaffirm our commitment and responsibility in honoring relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the First Nations, Inuit, and Métis people that call this nation home. Please join us in considering how we can each, in our own way, move forward in a spirit of reconciliation and collaboration. So a little bit of housekeeping. All of the attendees today are in listen-only mode. There is a question box to ask questions throughout the presentation. Those questions will be held until the end for a discussion session. So if something comes up as you're going, please feel free to jot it down in that chat box, in the question box. The session today is being recorded and it will be posted at a later date to the website. So you can go back and refer to it, or you can let other people know that they can check it out as well. And as I mentioned, the event is being presented in English with the option of simultaneous audio translation in French. So today we are here to talk about supporting the mental health of public safety personnel through allied healthcare. And we have 3 wonderful speakers with us today. Dr. Nadia Alim is a psychiatrist and mental health lead specializing in occupational psychiatry with a focus on disability management and workplace mental health. She is also an assistant professor at the University of Toronto and a national educator on mental health in the workplace. Dr. Megan Edgelow is an occupational therapist who works as a clinician, researcher, and educator. She is an assistant professor at Queen's University in the Faculty of Health Sciences, where she teaches and supervises students in occupational therapy, rehabilitation and health leadership, and health professions education programs. And Shaylee Spencer is a registered social worker, and she is CIPCERT's clinical operations manager. In addition to some incredibly valuable lived experience, Shaylee has been working in the human services field for over 14 years and has been involved extensively in research related to topics specific to public safety personnel. Thank you to you 3 for joining us. Is there anything you'd like to add about your bios? We're just so happy to have you here with us today. So to get our presentation started, Shaylee is going to set the stage for us and talk a little bit about mental health in public safety personnel.
Thanks, Kimberly. Hello, everybody. I was asked to speak about the trends, challenges, and interventions related to public safety personnel and mental health. I do find myself in a unique situation when speaking about PSP-related topics, as I am a child, sibling, spouse, friend, and former PSP. I have spent a lifetime watching family members take pride in their careers, protecting their communities, attending community events, advocating for change, but ultimately their experiences led to an inability to cope and function post-career. I've yet to see PSP involved in my life and those that I work with complete their line of duty unfazed by their experiences. On the next slide, we talk about public safety, or PSP in Canada. The definition of it, this refers to those working in various public safety professions, including but not limited to the list that you see on the screen. Generally, these are individuals, both career and volunteer, that have decided and dedicated themselves to the protection and safety of their communities. Language beyond the concept of first responders was adopted in attempts to be inclusive, as some PSP are more visible than others, but despite their proximity to the events or the experiences that they engage in while they're working, all are involved and impacted in different ways. Next. As we know, PSP are regularly exposed to life-threatening situations, witness to human suffering, are required to make impactful decisions quickly, and function on high stress. PSP reports feeling high levels of emotional burden. This means, as a form of coping, PSP create emotional distancing, which doesn't stop at the end of their shift, and it potentially engages in changes in their personality constructs over time. Studies reveal that they are at a heightened risk for conditions like post-traumatic stress disorder, depression, and anxiety. Several factors exacerbate PSP mental health challenges, and these include unpredictability and intensity in their work, chronic stress, shift work. This work also impacts their sleeping abilities or patterns, burnout, moral injury, occupational stress injury, and there's a long list that goes on with that. PSP are encouraged to maintain composure during critical incidents, and this brings about the philosophy of Stoicism. These ancient Stoic traditions often manifest in the organizational encouragement of PSP members, developing and maintaining mastery over their thoughts, feelings, and attitudes, particularly when they're engaging in chronic or stressful circumstances. The expectation to maintain a tough exterior can deter first responders from seeking help, fostering an environment where mental health issues are underreported. The stigma, combined with a lack of adequate mental health resources, makes it even more challenging for those that need to seek and receive supports. Out of this comes perception from society members on how PSP should present, expectations on what protection looks like, and PSP developing expectations of themselves on the hyper-controlled skills that they need to complete their job-related duties. Maintenance of stoic responses in crisis situations may mitigate the emergence of potentially interfering personal emotional reactions. Therefore, a paradigm shift is required from communities, organizational leaders, and PSP themselves to allow space for the evolution in perception around mental health wholeness for PSP. On the next slide, we take a look at suicide and thoughts pertaining to suicide. On this slide, you can see at the bottom middle, there's the Canadian public, so they call it general population, and the levels are the percentages of suicidal thoughts that they may have over a lifetime or within the year. And then we see that it breaks down into other demographics within PSP. So there's correctional officers, paramedics, and we see that the numbers here are a lot higher in first responder or PSP careers than they are in the general population. PSP do report not identifying that they're struggling as much as they are until they hit what they may define as a low. They have also reported not wanting to engage in services where they may see clients or other members of the community. And there is PSP that report being really fearful of talking openly about thoughts of suicide because they're concerned about how it may impact their career as they move forward. Next. We often look at mental health concerns with labels and in boxes and all those things, but we do really need to focus on behaviors. And sometimes we can see the behaviors a lot quicker than we can see just the whole picture that would be required for that specific label. So I did pull some quotes that we see commonly when we're working with first responders. And so I'll just go over them really quickly. So the first one there says, "I don't enjoy social gatherings. I'm not comfortable. I can't trust anyone. Hate at first sight, if you will." Next, PSP reported, I have seen things you could never imagine. They don't know that I'm so impacted by some of these things that I've witnessed. I sit in the shower and cry so no one will know and I can maintain my image. The next, and we see this quite frequently, a PSP reported, I feel angrier than I should. I can't seem to let it go. Another PSP reported, I have problems in my personal life, just like everyone else. People seem to assume that I don't. On the next slide, we see a few more. I was taught tools to manage my mental health from a previous therapist. There isn't always time for that, so I just push through it, which we do see quite frequently. Another PSP indicated, when I am done my career, I want to be married to the same person. This is a pattern that I've seen really increase over the last 2 years, so just that important focus on that relationship. Another PSP reported having nightmares after seeing a client in an accident. And lastly, I thought my organization would support me. It was a part of my job, but at the end of it, they didn't. And so that would be a possible example of organizational trauma that people are experiencing. Next. So when we think of conditions like PTSD, stress, and anxiety, reflect on the mind-body connection. And as indicated previously, there are events that PSP experience that condition the body to have responses where people feel unsafe and are required to respond in a manner related to survival. There's a difference between feeling unsafe and then being unsafe, and problems develop in part when PSP are not able to differentiate between those two. One tool that clinicians use to reflect on coping or functioning is this model, which is called the window of tolerance, and it was developed by Dan Siegel, and it describes the optimal zone where your mind and emotions function in balance and control. Within this space, daily life feels more manageable and stressors can navigate with greater ease and resilience, and we see that in the green piece of the window of tolerance. Sometimes with PSP, we have something called a fake window of tolerance where we're functioning what we think is fine, but maybe necessarily not, and perhaps other people are seeing behaviors from us that we're not really aware of. When we go to work, perhaps we're in that fight or flight mode. It sends us into that hyperarousal stage. And then when we get home, we may just want to disengage completely, putting us in that hypoarousal stage. So we can fluctuate in this up and down quite frequently. And again, we see problems when we're not able to maintain coping or resiliency factors that keep us in that green window. Next. Talking about systems that surround first responders, or PSP, we do need to look at the impact that these careers also have on their families. And so there's a ripple effect that these careers have on their families. 5 points that I wanted to point out. So a first responder trauma can lead to secondary trauma in family members, causing emotional and psychological strain. Families of first responders often experience chronic stress and anxiety due to the unpredictable nature of their loved one's job. There is an importance of effective communication and maintaining strong relationships within the first responder or the PSP in their home environments. This is something that stands out to me in particular, being a child of a first responder. Children of first responders need tailored emotional support and resilience building strategies to cope with their parents' trauma. Actually, a couple of weeks ago, my mom had made a comment that she felt like she had kept myself and my siblings very protected from the work that she had done and the emotions that she had experienced, which really wasn't the case. She was obviously not aware that we would often sit outside her bedroom and listen to some of the things, the emotional responses she was having as that was going on. And then seeking professional help and utilizing community resources can significantly aid families in managing impacts of first responders and trauma. And so just to kind of pull this together again, if we go to the next slide, there's some quotes from PSP families that we have that I pulled. So a first quote from a PSP family member: "This is the 5th Christmas that so-and-so has missed. Our 5-year-old is yet to know what it's like to have the entire family present for Christmas morning when they're opening gifts." Another PSP spouse indicated that after 35 years of marriage, they decided to leave and they were tired of being less of a priority than the uniform. Another PSP spouse shared that they share locations so that they can track where their partner is at all times, and they often are called out to very remote places and they want to ensure that they are safe. And all of a sudden, I noticed that I was walking on eggshells. They seemed easily agitated. I didn't recognize this person anymore and really wasn't sure what to do about it. So when we think about supporting PSP, it's important that we think about supporting the systems that support them as well and finding a systematic approach to that. On the next slide, talking about addressing mental health, it is important that we do look at early intervention. Sometimes that's possible, sometimes it's not. We do have the concept of proactive versus responsive. Some people used to look at it as preventative, but when we think about the calls and the lifestyle that PSP live, it's not always something that we can prevent. So if we do build the skills and the tools that we need to address all levels that we may be impacted, it's important to do that, but also important to respond when we start noticing that things are not going so well for us. And just understanding that there is no one size that fits all. There's multiple modalities to address. If we think about treatment and a mind-body connection, there's physical activity, there's traditional therapies, peer support. There's a lot of modalities that can be beneficial. Sometimes it works for a little while and then you need to pivot, but it's important that that person finds what works well for them.
Thank you, Shaylee. So as Shaylee mentioned, there are a lot of different modalities that can be utilized to support public safety personnel with mental health. And that is why we've convened this panel today, because allied health professionals play a really important role in providing those supports. So I'm going to turn it over to Dr. Aleem, and she will talk about the role of psychiatry in mental health support of public safety personnel.
Thank you so much, Kimberly, and thanks everyone for coming and making time to be here. I'm going to give a little bit of background from where I'm coming from. So I work in Ontario currently, and for many years have had oversight over many of the WSIB programs, mental health specialty programs, which tend to provide a lot of service to first responders and public safety personnel. And so when I was asked to come to this talk, I just want to emphasize the important role of an interdisciplinary approach that includes allied health. And some of the concerns I have at times are an over-reliance on psychiatry and specialist care to be able to deliver mental health services in timely ways. Okay, next slide. So I thought I'd start off by talking about what a psychiatrist is, because many people who come to see me often don't know the difference between a psychotherapist and a psychiatrist and a psychologist, and granted, it's very, very confusing. So a psychiatrist goes to medical school, they're a physician, I've completed medical school, and I have a provincial accreditation through the College of Physicians. So I answer to a College of Physicians within my province. And usually what most people complete is a 4-year undergraduate degree of any type, usually sciences, but it could be of any type. Then you do a 4-year medical degree, so a general medical degree. And you do a 5-year residency program, 2 years of which is general medicine. 1 to 2 years is general medicine. And so we have this general medicine background in psychiatry, plus the 3 years of specialization within psychiatry. And it's often gets forgotten that within psychiatry, there's equal time spent learning psychotherapy and psychotherapy approaches, as well as medication management. And some people go on to do additional specialty training. So I did additional specialty training in addictions. Other people will have additional specialty training, say in child and youth care delivery. So it's quite an extensive journey and quite a varied journey. And what you will see for the most part is psychiatrists in the current medical system, most don't engage regularly in psychotherapy treatment. There's some that still do, and most provide medication recommendations, although everybody you should know has that training on both sides. Next slide. And so there's really only in the public system one way you can access a psychiatrist. So you can't go directly to a psychiatrist in the public healthcare systems across Canada. I'll try and refrain from being specific to Ontario, but this is nationwide. You cannot access a psychiatrist directly. You have to see your family doctor, primary care physician or nurse practitioner first. So someone from a general practice realm, that's what the GP stands for. And then you're referred to a psychiatrist by your primary care provider. In general, if you have private benefits, so benefits through your employer or your partner's employer, you don't have access to psychiatry through private benefits. But some insurance companies, most notably workers' compensation boards often have programs where you can access psychiatry if you have filed a work-related claim. So I'm going to say that one more time. So if you have a work-related claim through workers' compensation, many, and I'm not sure exactly which ones, province to province, but I would say many, if not all, you can access psychiatric care if there's authorization through your claim to do that. In my experience, most other insurance companies, most of them that I've worked with, do not offer psychiatric care through private benefits and insurance companies, but sometimes they'll do single assessments if requested by an employer, or sometimes lawyer requests single assessments. So you may see a psychiatrist through that private route, but you usually don't have ongoing treatment. So what can psychiatrists offer? So certainly, most of what psychiatrists do is provide a diagnosis. And that diagnosis can become really important for accessing care in a lot of different realms, whether it's in the private care realm or the public realm. And there's only two specialties that can provide diagnoses, and those are psychiatrists and a registered psychologist. So a psychotherapist, a social worker, an occupational therapist cannot provide diagnoses. So you usually need to see a psychiatrist to provide a diagnosis, or primary care providers, specifically, I'm not sure about nurse practitioners, but physicians, family physicians can provide diagnoses as well. Okay, so your diagnosis comes from a physician or a psychologist. And what a psychiatrist should be able to do is provide a diagnosis and provide education around what that diagnosis entails, and come up with a treatment plan for that diagnosis. And most treatment plans involve medications from psychiatrists. That's usually the specific request on consultation, but they may also include psychotherapy recommendations. Now, psychiatrists can provide treatment directly, so they can provide long-term treatment for both medications and psychotherapy. Unfortunately, given the high volumes of care that we see both in public and private healthcare systems, psychiatrists tend to do one-time consultations. And that's really because if psychiatrists at the current kind of volume of need we have right now versus the specialist capacity, psychiatrists would be full and nobody would be able to get any kind of diagnosis or treatment recommendations from psychiatrists. So based on the high need and the low capacity we have right now, most psychiatrists will provide single consultations. Those consultations usually involve medication recommendations that your primary care provider can follow, so instructions on how to prescribe medications, and may involve psychotherapy recommendations for referral to other community providers, including psychotherapists and allied healthcare providers, to provide psychotherapy recommendations. I should say I'm happy to answer questions around this at the end because it can be very confusing. Next slide. Okay, so again, we have three types of treatment. We have medications, psychotherapy, and then there's this other branch of treatment, which I get asked about all the time. And those are kind of the more physical modalities of treatment. So I think many people, by virtue of seeing movies and media, although maybe my media consumption is a bit antiquated, will have seen some media images of electric convulsive therapy, also kind of colloquially known as electric shock therapy. Now, that therapy is delivered in hospital. It's delivered only by psychiatrists, and it's a very, very highly effective treatment for depression. It's not a first-line treatment, given that you have to receive anesthetic and be in hospital and you have seizures induced. So it's like, it's a hard treatment, but it's very effective treatment. So that's really only delivered by psychiatrists because it's a very specialized treatment. So even amongst psychiatrists, very few psychiatrists deliver ECT. It needs to be delivered in a hospital. And usually you have like long-standing symptoms that are difficult to treat before you're referred to that treatment. Another treatment I often get asked about is transcranial magnetic stimulation therapy, or TMS or rTMS. This is a new and evolving treatment. And just to kind of dial things back to the description, this is essentially where magnets are placed on your head to change some of the neural pathways and neuroendocrine hormone release that happens in your brain to treat depression and sometimes anxiety. It was mostly developed for depression. Right now, that's still in most cases delivered only under the auspices of private care or research, and it's slowly becoming adopted across provinces within the public healthcare sector. So that's kind of a new and emerging treatment, which has quite a bit of evidence. And the way it was kind of launched is, as a kind of more tolerable treatment for ECT. So it wouldn't be a treatment you necessarily jump to right away. You'd usually try psychotherapy or medications beforehand. But if you were really struggling with symptoms and needed something a little bit more intensive, but maybe didn't feel completely confident in receiving electroconvulsive therapy, this could be an alternate treatment. There's also new and emerging treatments around ketamine, which I didn't put on this slide. And ketamine can even be injected as an IV dose, so an intravenous dose of medication, or intranasally, so as a inhaler. Again, that's in the realm of psychiatry. It's a new and emerging treatment. It's usually not part of public health care as a standard care, but really reserved for kind of treatment-resistant cases. So that is kind of a brief overview of what psychiatrists can offer and some of the treatments that you may commonly see being recommended within psychiatric consultations. Next slides. So I'm going to walk through a journey here of a client, and this is kind of an amalgamation of a lot of different journeys that we've seen over the years. And so Arjun is a 47-year-old who presents to his family doctor feeling more stressed at work. He works as a paramedic and has had more and more difficulty managing the stress of calls and just generally the stress of his job. So that's the shift work and personnel changes. And he's not been able to sleep. He says to his doctor, "I can't get the calls on my head. I'm not sleeping." So he sees his family doctor and he's prescribed a sleep medication and then referred to a psychiatrist in his community. So no workers' compensation has been filed. He's in the public healthcare system and been referred to a psychiatrist in his community. And then there's a 4-month wait list to see a psychiatrist. In the meantime, Arjun's using sleep medications and isn't getting any other treatment. He then talks to another person in his workplace and heard that people could get treatment through workers' compensation, but they need to see a psychiatrist to get a diagnosis before he can begin this claim. He's also read about PTSD and thinks he may have this diagnosis and would love to try an antidepressant medication, but again, is waiting for the psychiatrist before discussing the initiation of antidepressants. And so Arjun's case was very kind of specifically laid out for a few reasons. And we can go to the next slide. If you see, Arjun now has had very minimal treatment except for the sleep medication, and we're at 3 months later, and Arjun feels like his symptoms are getting worse. He's been attending more calls. His supervisor at work is now noticing he's not acting like himself, and he suggests Arjun takes time off work. He tries to get medical clearance to go off work from his family doctor who's on leave. He's seen at a walk-in clinic instead and gets a medical note approving leave from work. Next slide. Okay, so there's a few things that are a little bit concerning about Arjun's case. All of them really, focus on kind of the time that's taken until treatment can be initiated. So the first thing is this sounds like it's a possible workplace issue. And so, this could have been filed under workers' compensation a little bit earlier. You do not need to wait. All of this will be, you do not need to wait for a psychiatrist. My one takeaway is you do not need to wait for a psychiatrist. So, if you're filing a workers' compensation claim, you do not need to wait to see a psychiatrist. Workers' compensation claims can be initiated at work. They can be initiated by primary care clinicians, and they don't necessarily require a diagnosis. You can put forward the claim, and if a diagnosis is required by a psychiatrist, workers' compensation can take care of that once the claim is initiated. So if you suspect that you are struggling with symptoms that are work-related, please file a claim, because once you file a claim, you have access to a lot of care. There's also a lot of opportunities for treatment, including some that are through PSP.net and other kind of agencies where you can receive really good psychotherapy treatment. And what we know about difficulties with sleep and difficulties with trauma, I've jumped to point 3, is that psychotherapy can be equally as beneficial, if not more beneficial, than medications in a lot of cases, even with depression and anxiety. So if you have access to psychotherapy, whether it's your employer benefits or some of the new online programs that are emerging, including the ones through SIPCERT, there's lots of great resources that you can access, and you don't need to wait for a psychiatrist. And I think a lot of people kind of think that medications are kind of the answer to their struggles, whereas really good psychotherapy is equally beneficial in most cases. The other piece is most antidepressants can be started within a primary care setting. So if you suspect you need an antidepressant agent or would like to start an antidepressant agent, primary care clinicians can start antidepressant medications. They're kind of part of the standard practice of primary care. It's only when you get into 2 or 3 medications or really complicated medications that you really need to maybe wait for a psychiatrist to kind of make those recommendations, but certainly do not wait for a psychiatric referral to start care. And I say this only because this is going to create a huge bottleneck. And unfortunately and heartbreakingly, I see a lot of people waiting to see me until they start any care, where care can be initiated in many ways far before seeing me. And I think that's the last slide, and we're over to Megan.
Thank you very much. All right, Dr. Edslow, take it away.
Thank you so much, Nadia. So I'm going to talk about occupational therapy and what do we know about occupational therapists and some of the things that they do related to public safety, mental health. By way of background, I've been an occupational therapist for more than 20 years, and then I'm also an associate professor at Queen's. I teach some of our new budding occupational therapists, and I also do some teaching in other health sciences programs. So I still have a small clinical practice as well as working at Queen's. So I sort of straddle the clinical and the academic worlds. All right, so to tell you more about occupational therapy, so we are a profession that, you know, if you've encountered us in your own health journey or the journey of a loved one, there's a good chance that you understand what we do. But if you haven't come into contact with anybody, sometimes people don't know the ins and outs of occupational therapy. And also sometimes our title, the occupation, in our professional title makes people think that we only work on work or workplaces. And certainly that is something that can be part of occupational therapy practice, but it's not the only thing. And some of that harkens back to the fact that our profession is around 100 years old. And back then, people used the term occupation to refer to all kinds of different activities, and it wasn't so linked to workplaces the way it is now. So we've been around for about 100 years, give or take, depending on the country. And where the profession actually came from was a mental health setting. So often 100 years ago, that was more asylums or sort of institutional care. And then also we had a lot of involvement in the rehabilitation of soldiers who were coming back from World War I and World War II. And at that time, we referred to PTSD as shell shock. So people came back, we knew something wasn't quite right with them. We were trying to help them get back to their civilian lives. And so that's kind of where occupational therapy got started. But we certainly actually still do a lot of work with military members and veterans, but we also work across the whole spectrum of healthcare services. And so you might, if you have children, you might run into an occupational therapist, or OT as we're often called for short. You might run into them in the school system or a pediatric care setting. And then you may also, as people are aging, there's certainly OTs who work in hospital or community care settings. And often people work on assistive technology or redesigning people's home environments. So there's all kinds of different places that you might run into OTs across your lifespan and across the healthcare system. One of the places that I've always worked is in mental health care. And I've worked in community settings, and at this point in my career, I work in private practice, but still a very community-focused practice. So what we find with OTs is that we are often using a very practical, sort of functional, participation-oriented lens, which is different often than a biomedical or psychological focus. And so OTs can often be quite complementary to other professionals like psychiatrists or psychologists or psychotherapists. And so we're often working to help people function in their homes, in their communities, in their daily lives, doing the things that they want to do that are important to them. And then also we may find occupational therapy focused on people's work or workplaces. One of the advantages for OTs is that we can work directly often with people in their home environment, in their community, in their place of work, doing really practical things, whereas some other professionals may have more office or virtual-based services that aren't as sort of applied. So that's one of the real advantages that OTs have. So there's lots of literature about, generally in mental health practices, what are occupational therapists doing? So we see a body of research around working with people on employment or education. So those, typically productive activities that we might think of. OTs also work with people on psychoeducation, so understanding their diagnoses and how to manage their mental health, also how participation in daily life can be part of managing mental health conditions. We also see some of the more common things that you might have encountered where occupations might be kind of creative. We might work with people on routines and time use and structure and kind of, the balance of an overall day, having a good balance of activities or occupations that people are participating in. Sometimes people will need to relearn a skill or a habit if they've had something like an injury or an illness, or sometimes there's a new skill or habit that they need to develop that will help them manage their mental health condition. We also sometimes work in group settings or with families more broadly. And then we also see a growth of animal-assisted therapy where you might also find occupational therapists working. So one of the things that I've done in my research is try to better map and define how occupational therapists work with people who have experienced trauma. And so this culminated in the publication of the Occupational Therapy Trauma Intervention Framework, or also called the OTIF. And so this is a framework that gets occupational therapists thinking about how ready people are to move forward and helping them kind of reason through different interventions they might take. And it's also the framework is really based in trauma-informed care. So on the next slide here, there's an example at a high level of that framework. And if you're a potential occupational therapy client in the future, you don't need to worry about the details of this, but know that your occupational therapist may be using the OTIF or something similar to help them reason through, for people who might be at a lower stage of readiness, which we would often think of as facilitate. So someone who's scoring quite low in readiness for engaging in therapy, we might be really focused on building rapport with that individual. How do we set the stage for therapy? How do we get people beginning to self-regulate and cope out in the world or at home? And then as people become more ready for further intervention, we might think of them as being ready to activate. They might have more active therapeutic goals. They might be going through things like psychoeducation. They might also be more actively working on their daily routine, schedule, building important activities back into daily life if those things have been decreased because of trauma exposure and potential mental health diagnoses. And then also we hope that as we work with clients, we get all the way up to the engage phase where we're seeing built resilience, post-traumatic growth potentially, having people find, return to work if they've been away, or find new roles, new sources of meaning, new forms of productivity, and that they're able to really cope and self-regulate well as they're kind of graduating out of treatment. So that's a very quick, high-level example of some of the things that occupational therapists might be doing as they're working with public safety personnel. So where to find us? So again, some of you in our audience might already have encountered us, likely in the public healthcare system. So this, when we think specifically about mental health care, there may be an OT or more than one OT on an inpatient setting. Certainly in some of our specialized inpatient settings across Canada, where people might be going for a specialized first responder or public safety or trauma-focused program, you will very likely encounter occupational therapists in those programs, in those hospitals or clinics. You might also encounter occupational therapists out in outpatient settings. Also, often they are funded through community and home care programs. Also, you might find someone like myself who is in private practice who accepts extended healthcare coverage, or also occupational therapists who work in private practice might also work or provide services for workers' compensation systems across the country. They might do that within a clinic or within their own practice. And what we see with occupational therapy and workers' compensation is that occupational therapists are often being used earlier and earlier in the claims process. And sometimes for people who don't understand the profession, they might think, oh no, I'm being referred to OT. That means I need to go back to work right away. But that's not really how workers' compensation is often using occupational therapy. Often early in the process, the occupational therapist can get people re-engaged in life, working on coping skills, feeling more confident, re-engaging with family, with things in the community. And that return to function can be one of the building blocks for an eventual focus on return to work. So sometimes it's a misnomer that if you're getting sent, if an OT has been added to your care, if you're seeing an OT in a workers' compensation clinic, that the expectation is you go back to work tomorrow. Certainly not. We're really there often for a very graduated process that really begins by focusing on function and what's meaningful and important to people, before we're making really that formal return to work for people who may have been away. Other things we know as well, I did some research a few years ago, kind of tail end of the pandemic, and we asked public safety personnel through a survey about their experiences with occupational therapy. And so what we heard from the public safety personnel themselves, this was an Ontario-based survey, that they really found that their occupational therapist was helpful with those coping skills and those tangible kind of daily life things. So some of the quotes that came out of this research is talking about, managing coping skills. When the person was going back to work, they felt set up for success. They were able to get back, and this is a different person, the second quote here, they were getting back into the community, they were addressing their triggers, learning how to manage in real time. And then a third participant here talking about, getting back into public, feeling more comfortable in groups, and working through kind of those daily things like noise or unpredictable situations. So their OT was able to be there with them in that return to daily life or that return to work. And then other things that we know, this was a similar study where we talked to occupational therapists in Ontario who work with public safety personnel. We asked them, what did they think was sort of unique about what they were offering? And so they were talking about that functional approach, being able to be in the community with people, being able to sort of tailor to every unique case of what they need. And also being able to really focus on that real-time support and working on things beyond work. Often before people feel ready for going back to work, they need to have other things down, like being able to go back to the grocery store or get to the pharmacy. finding those leisure activities that are going to help them buffer against the stress of a challenging job or challenging workplace. So having a routine, a repertoire of things outside of work that help them manage daily life and also find some enjoyment. And then, so picking up on that case study that Nadia introduced for us, so we had Arjun, he was waiting a long time for some care. He finally got that workers' compensation claim underway. So if we imagine he's here with me today in Ontario, this might be a WSIB, mental stress injury claim. And so as part of this claim, early on in the claim, he's referred to OT services, and they really want to work on his home-based function because it's been a long time that he's struggling. And eventually he's going to a return to work program, but right now they want to use occupational therapy in his home life. And so some of the challenges that somebody in Arjun's situation might be facing is, has lost that activity tolerance. So finding that he's tired easily and spending a lot of time in bed. Sometimes this happens for people who've had poor sleep and a long wait for assistance as well. So he's gotten pretty socially isolated. He's having trouble getting back into those public spaces. And he does have a family at home. He's got a 7-year-old son and his wife, but he's really only interacting with them. And also because he's not really leaving the house a lot, this happens a lot for people. If you're not going out that much, you might not be paying as much attention to daily hygiene or changing clothes because it might feel like, why does it matter who's seeing me anyways? And often when people become disengaged from their daily routines, they might end up, even though they are home a lot of the time, they might find themselves contributing less to the daily running of the household. And sometimes when we look at public safety families, we see that this can contribute to some strain within the family system. So what an occupational therapist might do with Arjun is work with him in a really gentle, person-centered way to find a daily routine that meets Arjun's needs and that also considers the family system that he's living in. They're probably going to work on increasing that focus on self-care and building in more home-based activities. Probably with thinking about, how do we help Arjun cope with some of the stress of this re-engagement. And so we're going to work to sort of amp up that routine over time with more contributions to home and trying to work in family perspectives of what works best in that family system. And then also wanting to amplify, Arjun sounds like he's very alone and potentially relying a lot on his wife for that emotional support, which can get challenging for everybody. So what kind of social supports are there in the community? Is there some peer support that he could potentially engage with? Are there places that he used to be social before having some mental health challenges? How do we get him back to interacting with people and finding supportive people? And also what kind of things in the community could be meaningful for him? So what kind of did he used to go to the gym? Did he used to be part of a recreational or sports league? Did he used to play, cards with friends? What were those things that sort of made Arjun who he was? And so working on this routine, working on this re-engagement, working on this increased ability to be outside the home, that's going to help him get closer to return to work readiness over time. At that point, in Arjun's case, he's eventually going to a return to work program. In the case of Ontario, that's probably a program that employs a variety of different health professionals. So he might end up seeing a different OT. Also, depending on the province, you may find that the OT who sort of helps you get back into daily life is also the same person who follows you back to the workplace. So Arjun may kind of, if he didn't have access to a return to work clinic, he may work stepwise, continuing with that community OT to build up to more readiness to be back in the workplace. And so occupational therapists can really work on those daily life things, starting with the way people function at home, building towards community and work settings. And what we've heard from public safety personnel who've experienced OT treatment as part of workers' compensation claim is that they have really valued the practical and applied approach. And one thing to know as well is if you are listening, if you've got a loved one or you yourself have a workers' compensation claim and you don't have occupational therapy as part of your claim, if anything I've been talking about sounds like it would be helpful, approach your case manager and see, is there a possibility of adding an occupational therapist to your repertoire of supporters?
Thank you, Megan. That was fantastic. As an OT myself, I'm a little bit biased towards your portion of the presentation. There's some really fantastic questions to come up. So we will turn it over to Shaylee, and then once she's finished, we'll get to all these great questions.
Right. I was asked to speak about social work and its impact on working with PSP. I will focus on PSPNet, which is a leg under the umbrella of CIPSERT. One of the things that the team does, we're comprised of many things, but we do have a lot of social workers. One of the things that we do is we do research. So we gather data before somebody enters a program while they're engaging with it. And then afterwards, we also facilitate groups where we speak to PSP about their experiences and what they would find would be beneficial. And we implement all of that into the programming that had been developed. Next. Just kind of speaking on that clinical side, you can go to the next slide. Focusing on what our clinical or social work team does, what we really do is try to focus on the individual and how they're functioning, giving them skills or tools. If you meet social workers in other capacities, they can work with people in terms of providing resources and working with them very closely and how they engage with the environment around them. Just a quick note about, on the next slide, clients that engage with our PSPNet services. So to date, there's over 2,300 PSP that have completed the intake process for PSPNet, with more than 2,200 enrolling in one of our programs. So, and then additionally, we have been able to provide the well-being course for 235 PSP spouses. So we have services for both PSP and for their spouses. On the next slide, clients come with diverse concerns, with depression being the most common, followed by anxiety and PTSD. An increasing number come to proactively manage mental health concerns before things get too severe. So we do often see people wanting to sign up for the course and gather those skills and tools to assist them as they go on. It is important to note the results show that regardless of the symptoms, as well as severity of the clients, that they do benefit from the program. The information on this background is important because it shows that PSPNet is for all clients, regardless of what they feel like they're going through. The next slide talks about cognitive behavioral therapy. And so first and foremost, PSPNet is specifically focused on offering what is known as cognitive behavioral therapy, or CBT. Decades of research from around the world shows that CBT is an effective treatment for various mental health symptoms. This form of therapy is all about helping clients see that there is a link between what we think, what we do, and how we feel. What we know from research is that when we help clients with identifying, managing thoughts, behaviors, and feelings, clients experience meaningful improvements in symptoms and daily functioning. Because of this strong body of research, PSPNet is focused on taking information that is typically shared face-to-face and putting it online, making it more accessible for PSP. Next, most PSP we survey report challenges accessing mental health care. And so we identify this as being one of the barriers and try to mitigate that for people. So we do offer services that are online, and people are able to access them when they feel like it is relevant or when they have time and when they have the privacy to do so. Next. This difficulty in accessing mental health care happens for lots of reasons, but three particularly that PSP have reported to us. First, PSP have a strong preference for self-management in their symptoms, which is a great characteristic, but also means that they are less likely to seek therapy at times. Second, therapy unfortunately is often inconvenient and inaccessible for many PSP, especially those who live in rural or remote locations and may have time that is limited, or there's limited funding for actual face-to-face therapy. And third, as much as we work to reduce the stigma associated with mental health, privacy remains a concern for PSP, not just in the environment, but also within their workplace, wanting to maintain their confidentiality and some of the struggles they're experiencing. At PSPNet, we accept and acknowledge these realities and are focused on using research to help determine how effectively we can take face-to-face therapy and put it online to overcome these barriers, allowing clients to be more independent in their therapeutic process, making it accessible, private, and convenient for people. On the next slide, as our team, our goal is to use research to ensure that the clients receive an internet-delivered CBT, what they would typically gain from a face-to-face experience when engaging with a therapist. Research tells us that across different types of therapy, there are several common factors that contribute to positive outcomes, and these include feeling supported, gaining insight to help people feel unstuck in what they're experiencing, and being guided to make meaningful, actual changes in daily life, making things and people feel better with what they're going through. Next. So how exactly do we do this? We provide online lessons, typically over an 8-week period, that share the same core messages found in traditional CBT. When therapist support is offered, it's optional and is provided through secure messaging or through phone calls with trained and registered therapist. This format is convenient, private, and flexible, with the level of support tailored to each client's needs and preferences. Even though treatment is online, the course materials are thoughtfully designed to support different learning styles and to do the things that we would do in a therapeutic session, although you have availability to them whenever you want, and you have availability to them after you complete the course in your work with a therapist as well. They are designed to be supportive and to build insight and help people make meaningful change and achieve the goals that they want. Next. At the heart, it's okay. So some examples that we may have when going through treatment, and this is something simple, but a CBT question: what is it like to be me today in terms of what I'm feeling, thinking, and doing? And it only takes moments to ask, but it opens up space to identify what somebody may be going through and what they may identify as needing to change. So more specifically, someone might reflect on physically: what is my current level of arousal? Does it feel comfortable? What would I benefit from using a strategy to adjust it, either calm down, or do I need to get energized? On that mental or thought processing, what's on my mind right now? Could it help me to pause and use some strategies to make my thoughts more helpful and constructive? And behaviorally, what am I doing or not doing today? Is there something I could do more of or less than, or how can I go about creating an action that will help me feel and change these things? These questions don't require a lot of time, but they do paint a path towards a meaningful and manageable pattern of change. So we're breaking a large problem down into a smaller one. In PSPNet, we offer 3 different ICBT programs and focus on helping PSP with different concerns. Next slide. And again, next one. Thank you. The Wellbeing course is designed to support a broad range of mental health concerns. The PTSD course, as the name suggests, focus specifically on symptoms of PTSD. We've also recently launched a sleep course, which is designed to help PSP manage sleep difficulties, something we know that is common, and it is a challenge. We hope to translate this into French in the future. All of these courses are therapist guided and currently available in 6 provinces. Additionally, the Wellbeing course is available in a fully self-guided format to PSP, as well as their spouses throughout Canada. This does, again, offer flexibility. Next. Each course is grounded in decades of research conducted by both Australian and Canadian universities and has been carefully tailored to the needs of PSP with input from PSP. The courses are designed to be engaging and accessible, using a variety of materials to support learning and reflection. They are carefully prepared with reading supported by photos and diagrams. They have videos that bring to life the concepts that are being explained. There are case stories to try to present with some relatability, how people feel like they're not so alone, gain some insight. And then there's a lot of additional resources that people can access that look into topics like communications, again, sleep, relationships, various things. Next slide. The CBT courses are about building lasting mental health habits and that anchor PSP during times of stress. They don't shield PSP from sorrow or stress of life, but they can help the PSP carry stress differently, offer relief and possibly clarity, even though faced with ongoing demands of their work. The courses support PSP in doing the things we know in the longer term protect mental health. Things like developing healthy routines, cultivating thoughts that support their well-being, engaging in activities that are enjoyable, setting meaningful goals, and strengthening connections with others. And on the next slide, we look at the case study of Arjun, and in terms of PSPNet and what this would look like. Arjun would register for the program through an online portal, complete a series of screeners or assessment tools that give us an insight as to where he's going. He would speak with a clinician, which would then just do a welcome call, see what's going on, gather a little bit more data, find a clinician that's going to work with them effectively, get them started in the program, and provide information on the program so that they know what to expect. And then throughout the course, he would receive education on trauma or well-being, how his body is responding to the work or personal stressors, thought challenging and behavioral activation that is all supported once or twice a week by a clinician. We do promote or suggest that if people are finding that the course is beneficial, they can then loop into another. So they may start in a well-being course and then loop into PTSD or sleep. And we have a therapist or clinician support and guide them through the whole process, whatever Arjun would feel like would be beneficial for him. The next slide just shows you our online platform where you can go to register. Also, again, just noting that we do have that option for families to engage as well. The next slide just gives you a good insight or an oversight, I guess, about the different resources that we offer. So we do have moral injury, supporting a colleague when there's mental health. So there's a lot of resources that people are able to access, and these are all based in research as well. Next slide. Again, just to reiterate as well, we offer the well-being course to PSP families and significant others. People have support or reported this to be really great. I've taken this myself and found it really good, even in that messaging of you're not alone and some of these thoughts are not unreal or unrealistic. Next. Just a quick note on what is unique about PSPNet. It's free. You can sign up if you're a career volunteer or retired PSP. No referrals are needed, so we're trying to break down the barriers that way. It's private and confidential. Everything's held on a secure portal. It's flexible and convenient. It's tailored to PSP. We really take on that input from PSP. You do get a certificate of completion if you want, and this whole program is grounded in research.
Thank you, Shaylee. That's fantastic. All right, so we're going to go ahead with some questions. So if you do have questions for our panel, please feel free to put them into the Q&A box. The first question that came through is for Shaylee, and it stemmed out of the initial part of your presentation. So the breakdown of the suicidal thoughts by PSP sector, is that available somewhere?
Yeah, I had provided Carolyn the website where it is, and it looks like she
Perfect.
just posted it in the chat box.
Okay, perfect. The next question is for me again. How involved have OTs been with CPSERT research? They stated during their PTSD treatment, none were involved, and I can see where an OT would have been helpful.
Yeah, I think, in my experience with CPSERT formally, Kimberly, they now have Kimberly on staff who is an occupational therapist, but I'm not aware of an OT formally involved with the organization before then. So I think we may see a bit more of a presence in CPSERT research. I would certainly like to see sort of an expanded vision beyond some of the focus on psychology or psychotherapy, just personally, because I think there's a lot that can be offered there. And as I said, for people, when you become aware of the profession, and if you have something like a workers' compensation claim, it is okay to be asking a case manager, like, how can I get access to that? Or will that come in at some point in my journey? So where you do have things funded, you might, as awareness is built, be asking for that thing in the future. And also know that for people who may not have a workers' compensation claim or may not be able to get access to occupational therapy, sometimes if you have extended health benefits, if you look in the kind of nitty gritty of that plan, you might actually have some coverage for occupational therapy, and you could potentially look for a private provider as well. So I think we're seeing occupational therapy grow, but it is something that I would love to see more of a presence within CIPSR research, and then also more, people knowing to ask for it in their healthcare team.
Mhm. And I will just add there too that if your insurance doesn't offer OT, it's important just to tell them that they probably should. There is a big push towards getting that recognized as one of the allied health professions that's covered right along with physiotherapy and speech and language therapy and massage therapy, right? The OT should be in there. So don't hesitate to speak up and advocate for yourself to get that coverage. This next one is also an OT question. So psychotherapists seem to have a lot of leeway in methodologies, strategies, schools of thought that they can choose to focus on in their treatments. Do OTs have similar flexibility to work in different theoretical arrangements, such as behavioral versus psychoanalytical, or are the treatments more structured?
I would say that similar to other mental health providers who might be drawing from a broad range of knowledge bases, I would say that that is also true of occupational therapists. Where you may see them differ a little bit, though, from psychotherapists or psychologists or psychiatrists, is that occupational therapists, while they may draw from some of those, as the question says, behavioral models or psychoanalytical models, those are ultimately psychological models. So while OT may use some of those complementary things, we have our own scope of practice, our own body of research. We're probably going to be doing things that are more participation oriented, more activity oriented. And there, I won't get into the exhaustive amount of theories that go behind that, but we do have really our own lens. And while we may borrow from complementary areas, we will likely be more participation focused.
Thank you. Next question is for Shaylee. So will the courses, the therapist guided courses, be offered in BC eventually?
It's a good question. And we are working on going Canada-wide. There's a lot of things that come with it. But yes, eventually. We do have some clinicians that are attempting to be registered, and not attempting, but it's a long process to be registered. So we are working on that.
The next question is a little more for the group. So what constitutes or qualifies someone as a clinician who can submit a claim for members in their department? So we might need a little bit more information. So I'm assuming in terms of like if we could personally submit a claim for insurance, I'm not sure. So maybe if we can get a little clarity there, we'll move to another question while we wait for that. So Dr. Aleem, I have a question for you regarding how do psychiatrists balance that need for the medical diagnosis with the realities of the long wait times in the public system? You alluded to this a little bit about not necessarily waiting.
Mm-hmm. So I think that the landscape has changed a lot where, access to any kind of services through insurance companies or access to any kind of psychotherapy interventions used to really rely on diagnoses provided by healthcare providers. And now I think that world has opened up tremendously, specifically post-COVID. And so the reliance on requiring a diagnosis is less and less needed. So I would say if anyone is kind of sitting back and waiting until a diagnosis is received to explore any treatment options, and I'll refer to PSPNet as well, like there is no need to wait for a diagnosis specifically to start to explore therapy options. And as I said, psychotherapy is a great first-line intervention for most medical diagnoses, most mental health diagnoses or symptoms. So think about your EAP benefits, think about your employer benefits, think about your partner's benefits, your family members' benefits. There's lots of ways to access that don't require diagnoses. So it's interesting because I was thinking about the last question, and I have to say, like, I don't know the nuances, and so I'm going to declare this. I don't know the nuances of all the workers' compensation boards, and I'm not sure I'm even the expert to speak on how claims are processed or filed through Ontario's workers' compensation, because I don't work internally at Workers' Compensation Ontario. So I think anything that's specific to how claims are started, or what kind of disciplines can submit claims, or whether you need a diagnosis or don't need a diagnosis, I'm a bit nervous to kind of speak to that because it's very different province to province. I would say if you have a family doctor or primary care provider, they can provide diagnoses, they can certainly start, I safely feel they can start workers' compensation claims across the country, and most insurance claims across the country and in other realms. And so again, just remember that they can provide diagnoses as well. Even if there's a required diagnostic clarification with a psychiatrist, you shouldn't be waiting kind of for a psychiatrist specific diagnosis to open any doors.
Thank you. And right, so the clarification did come in with, can a psychotherapist be a primary clinician that could submit the claim for workplace compensation? And again, I think it does depend province to province. So you would need to check with your local regulations and with your employer on that question. Thank you for that. The next question's a broad one for the group. So Megan, you touched on this a little bit around misconceptions. So often people hold a misconception around occupational therapy, meaning when you have that OT referral, your employer wants you back at work. And that's what we're focused on. And I've run up against that myself, where people were hesitant to work with me because they were not ready. They did not feel ready to go back to work, and they were really guarded. What are some other misconceptions that PSP may have about accessing mental health support through allied health professions? Any one of you can jump into that one.
I agree with you.
Confidentiality. Sorry.
No, Shaylee, we both waited. You go. Yeah.
Yeah, we hear from PSP a lot of confidentiality as a concern. For us here at PSP, that everything goes into that confidential file, where really the only person that has access to it is yourself. So you can have access to that information. You request it, it's yours, and then you would choose to share that with other people. But we do find, or other service providers, we do find that people are really concerned about that.
Nadia?
I was actually going to echo Shaylee's comment that, you know, a lot of people are worried about confidentiality and underutilized EFAP programs or employer-based programs where you can get access to lots of different disciplines under a lot of employer benefits, which are rapidly expanding, thankfully. So start using them, because those programs do not have a direct link to the employer and don't share information with the employer, but it's a big kind of misconception and a big barrier to be able to access care. I'd agree with you, Kimberly. Like, every time I bring up occupational therapy, people think I'm immediately sending them back to work. So I think there almost needs to be a rebranding of occupational therapy and the diversity of what can be offered under the auspices of occupational therapy, as Megan very nicely outlined. And I think the other thing is people get really caught up in designations, right? Like, I'm not going to see a psychotherapist because they're not as good as a psychiatrist, or I need a psychologist over a psychotherapist. I mean, I personally don't believe in any of that. I think lots of therapists can be excellent in lots of different professions, and I wouldn't get caught up on designations, but more kind of the treatment that is provided and the fit with that clinician. And so don't go looking for specific designations. Find the person that's delivering the type of care you need and the person who you feel comfortable with, and can form a therapeutic relationship with.
Thank you. That's excellent advice. And I would also suggest that, you know, if you can meet one person, but that one person might not be a good fit, but you should continue to, you know, push forward and try to find someone who is an appropriate fit for you, because there's so many amazing people out there doing wonderful work that can support you. Thank
I
you.
think the other thing is, Kimberly, sorry, I'll stop talking after this,
That's
is
okay.
you can also have multiple providers on your journey. So
Yes.
if you see someone at the beginning and you think, you know what, we've done a lot of great work, I kind of feel like I plateaued, I'd like to try this kind of therapy, or now I'd like an OT involved in my care and try a different approach. Don't be afraid of that. Therapists understand that, and it's kind of a natural course of recovery. So um, don't ever kind of get stuck in one line or one groove, I would say.
Absolutely. Megan, did you have anything to add?
I would agree with Nadia, and often the recovery journey is long. And so maybe there's something early on that's really helpful. And like Nadia said, maybe you kind of plateau with it. It's time to try something else. Also, maybe you try something early on and you're not quite ready for it. Doesn't mean that it was the wrong thing entirely. It might have been maybe too intense at that time, or you needed a more gradual approach. Maybe whatever that thing that didn't work to begin could actually be useful in recovery down the line. So I would say don't write something off just because it wasn't a perfect fit in that moment. And also, all of the professions are different, and all of the providers within each profession is unique. And so I think Nadia spoke to that as well, that sometimes you're going to really gel with somebody and that's going to be a good fit, and sometimes you won't. And so maybe asking for a referral to a different provider, even if it's something you have to wait for, sometimes it is also about that person's experience level. And it's okay to want someone who's a particular gender, feel more safe with that. Like, that's okay. There's all kinds of things and all kinds of background experiences that people have that are going to make different providers a better or worse fit. And it's okay to acknowledge that everybody is unique, and sometimes you're going to have to try several different things along the recovery journey as well.
Well, this next question asks, this is more of a general question when it comes to PSP seeking help. I work as a peer support counselor with police officers and frontline staff such as dispatchers. I am in a debate with someone when it comes to PSP reaching out. I believe that ultimately it is on the PSP to decide when they are ready to reach out, and that we cannot force someone who is not ready. So a little bit of discussion around that. Thoughts?
I would say for sure we can't force people when they're not ready. There are different skills and tools, though, that we can implement to either provide somebody education about where they might be at, asking some curious questions, just helping prompt some of that thought process so somebody can gain some insight for themselves. But they ultimately do make that decision, register, do whatever they need to move forward on that. There also is sometimes that concept of motivation and people trying to measure motivation. That's difficult when you're working in a field like this as well, because as you do the difficult work, it becomes uncomfortable, and we may see the motivation shift and change. So just keeping that in mind when we're working with people, it ebbs and flows.
Thank you.
Yeah, and I would agree with Shaylee. You can't, someone has to be the one to reach out. And often, as much as we want something for someone else, when it isn't sincerely chosen by them, it really may not be impactful. Someone may be going through the motions to kind of please somebody else or get somebody off their case, but it really does have to be sincerely chosen. And sometimes that can be hard to watch from the sidelines, where you have a really good sense of what could be helpful for somebody and they're just not ready for it. But it is often a really personal journey and something that we can't make somebody be ready for. I would also agree with Shaylee that there are different clinical tools that may actually help someone consider, why they are or aren't ready, or what things could make them feel a little more ready. And it kind of goes into, Kimberly, if you don't mind, I'm actually going to jump into the next question, because the next question is really interesting from an OT perspective. It's kind of asking about this, like the idea of being proactive or being preventative, because often occupational therapists, the way the funding system works, you might only see them once you have an injury or an illness or something like that. But one of the attendees is asking about, what about seeing an occupational therapist before you're ill, or before you're having challenges? Could you see them proactively. This is something I would love to see more of. And we also see a lot of, thinking about from a more proactive lens, saying to all public safety personnel, like, have relationships with community mental health providers before you get to the point where you're like desperately seeking one. So if you have extended health benefits, or you have an EAP or some way to access people while you're actually still well and still working, having those therapeutic relationships in place, even if it's just like a once or twice a year check-in with somebody, can really be helpful for if you do have challenges in the future. You've already got those relationships and you have someone who might actually be looking for signs and symptoms before you're noticing them. And I think people could definitely proactively use occupational therapy, especially if they were to have some benefits in their extended health plans. You could find a community OT, you could see them a couple of times a year, you could be checking in with, how is my routine looking? Like, do I have things outside of work that are keeping me healthy and happy? How am I interacting with my family? What kind of community things am I engaging in? All of these things might help buffer stress over the long term. So I would say, yes, a proactive kind of, annual tune-up with an OT could be a really positive thing. And I would love to see more sort of proactive access to occupational therapy generally in the health system.
Yeah, I would echo that. I like to use the analogy of dental care. Like you don't not brush your teeth. Like you don't just wait for a rotten tooth, and we shouldn't do the same with our minds, right? We need to take care of our mental health just the same as we do with the rest of our health. So highly encourage checking it out. One of the questions that I'm curious about is kind of what are your hopes for the future integration of allied health support for PSP mental health? So what kind of strategies could we be implementing nationwide to have better integration?
I can speak to this a little bit. It really depends on the province you're in, but there are definitely some workers' compensation strategies. I see this prominent in British Columbia at the moment, where a lot of the trauma people who would have a trauma-related claim to theirs is WorkSafe BC. Their community providers in a lot of places are actually mandated to work in multidisciplinary teams. So you're not just kind of siloed and only receiving one type of therapy from the get-go. So I find that quite a promising model. And in some of my own research recently with length of claims, contrasting Ontario and British Columbia, we see actually dramatically shorter workers' compensation claims for public safety personnel in British Columbia. And it really does make me wonder about that, like early access to team-based care. We do see WSIB Ontario shifting to that model, and more they have been trying to set up multidisciplinary teams. And we see a lot of implementation of sort of increasing access to occupational therapy on those teams. So I think those are promising efforts. With the data here in Ontario, it's kind of early days to see what kind of impact that might be making. Whereas in British Columbia, they made that transition around 2019 to that multidisciplinary focus. We can already see the benefits in their data. So I'm hopeful that we will see some of those good things happening in Ontario as well. But each province is really different in how they're attacking things as well.
Yeah, I think I'd echo a lot of what Megan said. I think that's so interesting to hear about BC and so promising. I would love to see a greater investment in that in wellness programming. And I think allied health have a big role to play in wellness and wellness programming way upstream. I mean, in a glorious world, we wouldn't have workers' compensation claims. And there'd be a higher upstream investment. I also think there's a lot of like interesting ways to expand access to care, like PSPNet, and a lot of online wellness programs and intervention programs that are really interesting that can be delivered by allied health. I think the other thing is, and this is kind of maybe a controversial topic, but in addition to building interdisciplinary care teams within workers' compensation, hopefully within the community, I would love to see, and this is, I agree with you, Megan, it's moving, like the dial is moving, but I think a focus on functionally oriented care and less on symptom amelioration is the way we need to go moving forward. And, you know, certainly I can speak to the mental health specialty programs since like 2015, 2016 have been focused on psychiatry and psychology and symptom reduction. And there's been no discussion about how is this person functioning and what functional interventions. And now we're much better equipped to do that. But I think kind of reorienting everyone to like that functional model and how do we support improved functioning rather than reducing symptoms and leaving functioning out of the picture altogether.
Absolutely. Thank you. Shaylee, do you have anything to add?
My initial thought was it would be great if we could open up some of those gaps in funding and those pieces, but it was well said by the two.
Okay, well, we have only 5 minutes left, and I know a couple of our panelists have to dash out to other places. So I just want to take a quick moment to thank all of you for this really incredible information. I hope people are curious and will seek out further information about pursuing different allied health roles. We do have a couple webinars upcoming, one that I will tell you about right now. So talking about other modalities, we will be offering a webinar on using dialectical behavior therapy, so commonly known as DBT, and EMDR, which is eye movement desensitization and reprocessing. It's a mouthful, so we can just go with EMDR. That panel's coming up on June 25th from 1 and 2:30, that's Eastern Daylight Time. So please scan that QR code, get registered. Lots of really valuable information and discussion from some fantastic panelists who will be presenting that information. We also have PSP Connect, which is coming up on June 11th. And PSP Connect is essentially a peer group for PSP to attend. It is held virtually. It's held on a quarterly basis. This is for you to come talk about what's most pressing for you. What are your primary mental health concerns? How can we, give us your feedback, talk with one another, share insights and experiences. I think it'd be really valuable experience. So hopefully we'll see everyone there. And again, you can scan that QR code to access that information. If there were questions that you have that we didn't get to, please feel free to email us. I think our contact information has been raised. It's been put through in the chat box, and we will endeavor to answer those questions for you, send you resources. I encourage you to check out our website. Oh, they say they've been deactivated. Okay, we will fix that for you. The registration links, we'll get them. Yeah, they're in the chat box there. So please feel free to use those. Sorry about that. And if there's any other concerns, just feel free to email us and we'll get back to you as quickly as we can. Again, thank you so much, everyone, for joining us today. This has been a fantastic experience, and I hope to see everyone again soon. Thank you.
Thanks, Kimberly. It was a pleasure.
Thank you, everybody.
Okay, take care.
Bye.